and a little bit of classification. How does it happen? What caused the heart failure? And most important, of course, the three main thing I want you to know about heart failure is what does it cause it? How do you diagnose heart failure? And how do you manage heart failure? This is a very basic principle of management we'll do for you guys. All right. It's something that you will see very frequent, especially in elderly population. I think our prevalence for heart failure is very high, especially in our elderly population. Okay. Um, Malaysia has published its own heart failure CPG for the fifth time last year, and there's a lot of new updates, especially the one done last year. Uh, and in terms of the pillar of pharmacological management of heart failure has changed drastically throughout the years, especially with the new introduction of different class of heart failure medications. So it's a syndrome, it's a clinical syndrome, which is the end stage of most of the heart disease. Globally, it affects a lot of people, and Malaysia, the prevalence is about 7%. Means almost 1 in 10 of people have heart failure. So in Southeast Asia, the patients tend to be younger. Usually, they are 60 years old and above. Uh, Almost 10 to 15 years younger than European people and especially patients from the West. I think probably because um, the diet is a little different and their physical activity also different compared to Western community. Okay, there's a little bit of epidemiology from Malaysia in terms of heart failure. You guys don't need to remember this. Just roughly know how is the burden of heart failure in Malaysia. So the median age is quite young, it's 59 to 64 years old, meaning that almost half of them they are actually just about to retire to enjoy their life. They end up in heart failure. Okay, and median stay because of heart failure is almost 1 week. Mm. And if you compare to overseas, is even longer. The mortality can be as high as almost 10%, and 30-day mortality of admission because of heart failure is as high as 15%. Similarly, if let's say you're admitted for heart failure 1 year later, the risk chances of you to pass away due to heart failure is almost 50%. So in short, you many people actually has heart in Malaysia that has heart failure at around age group around 60 years old. So the burden is high and is causing a lot of trouble, especially to us as well, the practitioner, because they are still considered young and you need to spend a lot of time, spend a lot of money to help them. Okay, you need to know about this. Okay. So just remember, Malaysia, the burden of heart failure is high and is constantly increasing and causing a lot of costs for in terms of the socio-economic burden. So maybe this one is too difficult for you to imagine. Just imagine the current burden in our cardiac clinic right now. You guys know what is echocardiogram? Right? It's a sonography of the heart to measure the heart function. Can you guys guess what is the waiting time for the echocardiogram right now? If let's say you get a form, you go and get an appointment. Do you know what? Can you guys guess what is the waiting time for you to get an echocardiogram done in cardiac clinic in a rough guess? Any number? Give a number.
I want to say 2 days. Days.
Or 2 days? Anyone else? 2 days is too short. 2 days is impossible. Even if you go private, also may not able to do in 2 days. Any other number?
2 years?
Yeah, you are good, man. Number is 2 years. So if you go and get the form, you probably will get it done in 2026. Yeah, the appointment is 2 years time. So can you imagine if you look at the data just now, patient die half of I mean the chances of them to die of heart failure is almost 30% at 1 year. So you may even die of heart failure before you get the echocardiogram done. That is how bad our burden for cardiac disease or heart failure, ischemic heart disease right now in Penang. I think not just Penang, even in whole Malaysia also, the waiting time is getting longer and longer because the number of people are increasing. Okay, all these are still back to basic things that the risk factor for ischemic heart disease is the burden is increasing. Number of patients with diabetic uncontrolled hypertension, they are increasing drastically, and the patients are getting younger and younger. So that is a huge problem, and especially in a few years' time, you even see more patients coming with sudden heart failure. Okay, so definition of heart failure is a syndrome due to any structural or physiological abnormality of the heart, causing an inability to meet the metabolic demands of the body or ability to do so at higher than normal filling pressure. So, to make it short, it does not pump enough blood to supply the vital organs. Our heart, the main problem, main function is to pump, they contract, they relax, to squeeze out the blood, the oxygenated blood to target end organ, including your kidney, your lungs, your liver, and the brain. When they cannot do so, failure to match the requirement is what we call heart failure. Okay? So what are the signs and symptoms? I think you guys should exposed to this before. So when the patient does not have enough perfusion, what will happen to the systemically, their blood pressure will become lower, they become cold and clammy because of the hypoperfusion. They will have congested lung because of the poor heart function. They'll get heart failure symptoms including shortness of breath, leg swellings, and easily tired. Other signs that you can see would be raised JVP, uh, ankle edema, eating edema, and when you're scouting the heart, the lung, you hear crepitations. Okay, older people, their symptoms may be slightly different. They may just present with loss of consciousness, dizziness. They even go into delirium, means they are less conscious, they talk incorrectly, um, and they have recurrent fall because of dizziness. Okay. So how do we classify them? This one not so important for you guys, but there are ways in the guidelines you can classify acute heart failure, chronic heart failure, left-sided or right-sided heart failure, and you can classify into different clinical contexts like whether this patient is a compensated heart failure, decompensated heart failure, or end-stage heart failure. This is not very important. Just remember the important one will be acute sudden heart failure or chronic or acute on chronic. Or maybe the more important is whether it's compensated or decompensated heart failure. Okay? This is good to know. There are other ways that we can classify them. Depends on how good is their ejection fraction. This provided if you have your echo easily available. The reason why this exists is because with this classification of stages of heart failure, you can see or you can class their improvement with treatment, whether they can improve from a reduced ejection fraction to a mildly reduced ejection fraction or preserved ejection fraction. Their importance, especially when you are doing aggressive treatment, see whether they got any improvement or not. But it won't be useful if you have very restricted access to echocardiogram, uh, which you don't get to see to get the assessment in 2 years time. So this is just something theoretically available for you to classify them, how bad their heart function is at the baseline. Okay, this is something you need to know. The NYHA classification we talked about last lecture. So remember, there's class 1 to class 4. Class 4 means is the worst thing, means that they cannot do anything. At rest, they are shortness of breath. They cannot do much because of symptoms at rest they're having, congestive symptoms, even when they are resting on the bed. Okay. While class 1 that has no limitation at all, they can do whatever they want. They can go and climb the stairs without feeling tired, shortness of breath or palpitation. Okay. Then in between 2 and 3, class 3 means there's a marked limitation. They can at rest, they're okay when they're trying to walk few steps, together with their peers, walking upstairs, all they can't do. Okay, class 2, they can do something, but not something strenuous. Okay, all right. So, what do we mean by left-sided or right-sided heart failure? So, remember our left side, left atrium and left ventricle, their job is to pump oxygenated blood from the left ventricle through the arch of aorta and to perfuse the vital organs. Okay, while the right side of the heart, it will pump the blood from the right atrium to right ventricle and out to the pulmonary artery. Okay, it's the ballet on the blue is the right side, the left, the red color is the left side of the heart. Okay, so if your left side is failing, left side heart failure means that the left side of the heart cannot pump enough oxygen to rest of the vital organs. So you get pulmonary congestion, you get shortness of breath. While right side congestion, the congestion mainly will backtrack to the lung, to the liver. Okay. So this is what I mean just now. So if let's say you have left heart failure, you have reduced in cardiac output, so reduce in other tissue perfusion. So you have hypoxic periphery, you look blue, you have peripheral hypoxia and cyanosis, and you easily get the pulmonary congestion because of the left side heart failure. You get congestion like crepitation in the lung, you get acute pulmonary edema. For right side of the heart, the congestion mainly will go backtrack to the liver and also your other abdominal organ causing ascites. You tend to have liver congestion on right side heart failure. But a lot of time what you are seeing in the community, there's something what we call it congestive heart failure. Um, means that when you have left-sided heart failure, when the fluid is accumulating enough in the body, the failure will progress to involve the whole heart as well. Uh, because your blood has nowhere to go, isn't it? Left side ventricle, it cannot pump out the blood. So what happens is that the blood will just keep on building up to the left atrium, and then eventually you backtrack and causing congestion on the right side. This is what we call congestive heart failure, where the left side and the right side actually fail together. That's what we are seeing. Hey, this is just a graphic to illustrate what's happening. When you have left side heart failure alone, typically they comes in with lung congestion. They have difficulty breathing. They have leak swelling. They have crepitation and auscultation. Those are the typical presentation. While isolated right-sided heart failure, they're mainly presented with the lung problem. They comes with mainly just dependent edema, abdominal distension. That's how the right-sided presented. So in terms of etiology, I just want you guys to remember the important one because there's too many things here. So the common cause of the heart failure is still ischemic heart disease. Ischemic heart disease, coronary artery disease is the main causes, make up the largest proportion of heart failure. Because you can have other less common causes of heart problem, like the valve problem. Your mitral valve or aortic valve disease insufficiency can give you heart failure as well because of the valve leakage. And then the muscle problem of the heart, cardiomyopathy, also can give you this problem. While right-sided heart problem, most common cause is still the left-sided heart failure that lead to the congestive heart failure, and the right-sided valve problem. Anyone clear about this? Is it confusing or not confusing?
It's okay.
Okay, this one a bit. So this is the main pathophysiology of how does the congestive heart failure develop. So the main definition of the heart failure is because it is that the heart unable to give you sufficient cardiac output or cannot pump out enough blood to meet the perfusion and oxygen requirement of the body while maintaining the normal filling pressure. It can be because that the heart cannot pump correctly, the heart cannot contract hard enough to pump out the blood, or it can happen because the heart cannot relax enough to refill. Okay, so what happens is that um, your body will try to increase the stroke volume. They will try to ask the heart, hey, you're not pumping enough blood. Let's pump harder to squeeze out whatever the blood is. And with that compensatory mechanism, your heart muscle will try to increase because of their work harder. The wall tend to be hypertrophic, and the wall thickness will increase through remodeling. And because of this, will causing the symptomatic nervous activation, activate the RAS activation. All this will lead to more fluid accumulation in the body. So it becomes that it's like what we call it. That all this mechanism is supposed to help your heart to pump more blood, but in the end, it causing more problem because of the ventricular remodeling. That end up the heart has to pump even harder and increasing further oxygen requirement. This is important. This is an important slide. Etiology is important for you to remember, especially in exam. Like I said before, majority of it is still coronary heart disease, followed by uncontrolled hypertension and valvular heart disease. Okay. Other less common disease is there, especially when you rule out other causes. Good to remember is congenital heart disease, of course, then toxic. These are things that we commonly see. Toxic cardiomyopathy, especially alcohol, and also substance use like IV drug user, cocaine or methamphetamine drug use. So theoretically, alcohol and drug use causing cardiomyopathy, they are reversible, but you need time. Uh, you need at least 6 to 12 months of complete abstinence for you to regain the heart function. Okay. Other less common causes no need to remember. Okay. So just remember, important one is your ischemic heart disease, coronary artery disease, and controlled hypertension, valvular heart disease. You want to remember more will be toxic causes like alcohol, uh, illicit drug use. And also remember the endocrine problem like thyroid disease, uh, hyper or hypothyroid disease, both can cause heart failure. All right. This is one of the another mnemonic to remember the causes for acute decompensation of heart failure. So a lot of time patients when they have ischemic heart disease, they they will go through the stages of compensated heart failure before going to decompensation because their heart will try to pump harder first. So compensated means that patient can still walk around without oxygen. Uh, they're still feeling comfortable. They are not YSA classification maybe class 1 and class 2. And when you go to decompensation, they'll become hypoxic. They'll require oxygen. They will have a very overt heart failure, right? So what are the causes for acute decompensation? Most of the time, patient comes in, there must be a secondary insult that causing the heart to decompensate. One of it will be they don't compliance to their fluid restriction. A lot of patients when when they are at stages of compensated heart failure, when their EF is down, patient will the doctors will recommend them to cut down their fluid intake. Okay, they will ask them to reduce it maybe to around 1 liter per day. The patient is not compliant. That's one of the causes for decompensation. Other causes you can remember it by this mnemonic champion. C means that coronary artery disease. If they have another new episode of ACS, they can cause sudden worsening of the cardiac contractility, causing worsening of the heart failure. Uncontrolled hypertension, if they miss their medication. New onsets of cardiac arrhythmia like atrial fibrillation, and other common causes is infection. That's commonly what we see in the ward. Whenever they have URTI episode, pneumonia or urinary tract infection, all these can easily tip them towards the decompensation of the heart failure. Okay, this is important as well. Whenever I say important means that there are chances that you will go into exam. So this is important as well. It's something very important for you to know and understand the concept. Uh, what are the other factors that can lead to decompensation? Uh, it's just another way of putting it, remember it lah. Just now it's by mnemonic. This is uh, by different classification of patient factors, cardiac causes or systemic causes. So most common it is still systemic causes like infection and not compliant to uh, fluid restriction and uncontrolled hypertension or the new episode of ACS. Those are the common things that we are seeing. Everyone get that? Important. Okay, so how do we diagnose heart failure? So of course, it's by the symptoms. Patient will have uh, reduced effort tolerance. They will tell you that they're unable to uh, walk as far as what they used to do. They're unable to climb upstairs. They'll have shortness of breath when going upstairs, one or two flights of stairs. They will have problem of intermittent chest pain, and they may also complain of symptoms including orthopnea and PND. Those are the typical heart failure symptoms. Orthopnea means that they need to have they need to sleep with a few pillows. They need to sleep with elevated bed, elevated headrest, and paroxysmal nocturnal dyspnea means that they will wake up in the middle of night because of shortness of breath. Okay, those are the typical symptoms that can come with. Clinical signs, they will have leg swellings, they may have raised JOP, and lungs will hear crepitation. Okay. And then investigation, first line investigation, you're still looking at the ECG, chest X-ray, and the proBNP. So what do you expect to see in ECG?
We expect a low QRS. A low ST. I think so.
Yeah, so in this group of patient in ECG, mainly we want to see is there any previous ACS before or not, or is there any ischemic changes. So particularly you want to pay attention at any Q wave, like what we talk about. Any established Q wave means that it's telling you that this patient got previous ACS event. And we wanted to see any ST changes or not. Is there ST elevation? Is there ST depression? And also we want to look at the overall what is the cardiac rhythm. Is this atrial fibrillation or not? Those are things we're interested in. What about chest X-ray? I will show you the
Chest X-ray maybe to see if like there's fluid.
Yeah, I will show the photo in a while. And pro-BNP is something natriuretic peptide. In short, we call it BNP or pro-BNP. Is to something to tell you is there any potential heart failure or not. So this natriuretic peptide is a natural protein that actually produced by our 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 body cells, where it's actually situated in the right atrium. So when left and also right atrium. So whenever you have a heart failure, your chamber is going to be dilated because your heart cannot pump out fluid, right? Cannot pump out the blood. So they will backflow and you're causing dilatation of the chamber in the right atrium and also left atrium. So when the chambers are stretched, those protein will be produced from there and you will have elevated BNP. That's how these things comes up. So in heart failure patient, their BNP is always high. Uh, but if let's say it's very low, so it makes it less likely. And then so if the test is normal, and as suspicion is very low, so make the heart failure actually quite unlikely, no? So, but of course, we don't really reliable much on the BNP because sometimes they can still be normal pro BNP, but you have heart failure. So pro BNP never really used as a screening tool for us actually, because one is because it's expensive, not every center has it, and when it's negative, it does not give you 100% say it's no. So symptoms is still very important, and of course, echocardiogram is still our gold standard to tell that does the patient have reduced in ejection fraction. But like I say, in our hospital, the waiting time is 2 years. So this will be a problem if you wanted to just based on echocardiogram to call someone to have heart failure. So in the end, uh, clinical examination and by relying by the ECG, chest X-ray, those are what we are commonly using in our daily life in our ward. Okay, so when you have suspicion of heart failure, you try to arrange ECG, chest X-ray. Those are things you can do. You try to arrange echocardiogram, and at the same time, you want to work out the common cause of the heart failure, which is ischemic heart disease. Right, I think this is just a repetition of what I have mentioned earlier. The left-sided heart failure. Uh, some people tend to remember better when there's a graphic. So that's why people start to draw all this now. So if you find this useful, then it's good. So patient on left-sided failure, uh, mainly their leg will be swollen, okay, their lungs will be congested, they tend to be blue. All these are telling you all the hands they tend to have cyanosis because of poor perfusion, right? With right-sided heart failure, their leg tend to be very swollen. They have enlarged liver, enlarged spleen. But commonly, with patient with congestive heart failure means that they have both of the symptoms now. Again, this is repetition. When things keep on repeating few times, that means they are very important. Okay. Yeah. So just remember the elevated JP, the crepitation, and the pedal edema. The rest is okay. Yeah, I want you to remember this. Yeah, sign of heart failure. Remember hypoperfusion, cold periphery, uh, hypotension, congestion, and peripheral edema. This few lung crepitation and brachial P. They keep on coming out all these few terms. All right. Okay. I think this one comes out in last year's exam. Last year's exam, there's one photo of pitting edema. And then the question is, what is the causes? No, the first question is name the physical sign. And the second question is, what are the potential differential diagnosis for the above clinical signs? Okay, so this is the answer. Whenever you have leg swelling, doesn't mean that you just have heart failure. There are also other differential. So any causes that can cause fluid retention, increase in your total body fluid volume can cause you pedal edema. So number one is the heart problem. It can be ischemic heart disease, heart failure, or pericardial disease. Congestive liver failure can give you fluid overload and pedal edema. Because nephrotic syndrome, because of low albumin and fluid overload, it can give you pedal edema. Protein losing enteropathy, they are losing a lot of protein and albumin from the body and causing interstitial edema. Of course, ESRF, end-stage renal failure, they cannot remove excess water, they will have pedal edema. Okay. Yeah, better put a star on this one. This is a very important thing when you go to ward, when you go for clinical exam. This thing will keep on coming back again and again. Okay. So basic investigation when you want to assess heart failure, ECG. ECG, you want to look at the basic metabolic profile of the patient, and of course, your most important will be your echocardiogram. Yeah, good to know. No need to remember. There's a cutoff for the BNP and anti-pro BNP. No need to remember a number. Just remember that when it's elevated, it tends to tell you, oh, there might be heart failure. Okay. So this is important. This is the example of the congestive chest X-ray. So what you see here is that, do you see the hemidiaphragm or not? Do you see the diaphragm?
No.
Cannot.
Show what is diaphragm. If you don't know what is diaphragm. Okay, normal chest X-ray. So if you see a normal chest X-ray, you can see my screen, right? Yeah. Can you see this normal chest X-ray?
Yes.
Yeah, normal chest X-ray, the heart, if you look at it, the shape actually, there's something what we call cardiothoracic ratio. This is the cardiac ratio. You look at here, my scroll, this is your cardiac ratio. This is a thoracic ratio. So when we say cardiothoracic ratio, means this one, this length, divided by this length. It should be less than 50% normal heart. Okay. When they are congested, you can see, you can, this is your heart here. It's definitely more than this length, isn't it? So this is increasing cardiothoracic ratio. And if you look at it, you can see your diaphragm very nicely here. Okay, this is a dome, the diaphragm dome, you can see the arch properly. But what about this one? You don't see it anymore because there is a effusion bilaterally. There's a pure effusion bilaterally. And you look at all these pulmonary vessels like that. All these are look like a bat wing like that. So all this what we call bat wing side, upper lobe diversion. This is pulmonary congestion. Compared to the normal X-ray, you can see very thin line. No, it's not so prominent, and the vessels is all equally distributed. If you look at this one, mainly the vessel all go up. They are diverted to the upper part because the lower part are filled with the fluid, so the blood has to divert up to have more oxygenation happen on the upper lobe. This is what we call upper lobe diversion. Right? Yeah. Other subtle thing you can see from the X-ray will be pure effusion. This is your fluid in fissures. But the pure effusion, this is very obvious. When you see something like that, you can see the hemidiaphragm. No? This is more subtle. You'll see something called curly B lines. So normally you don't see these horizontal lines here. All these are telling you that there are fluids inside the lung. Okay? It's the cardiac thoracic ratio I'm talking about. This length divided by this. Okay. So for cardiac assessment, these are the things that we commonly do either for ischemic heart disease or heart failure. Is equivalent things that we do like basics, basics hormonal workup, basics metabolic workup like your thyroid function, your diabetes and cholesterol control. And then to further risk verify, we'll be doing angiography, the angiogram, we'll do cardiac MRI, echo, and also exercise stress tests. Okay, so this one is okay. No need to remember this. All right, so how do we manage heart failure? So in management, in management, it's easier for you to remember. There's always a pharmacological side or non-pharmacological management. So non-pharmacological actually keep on going back to the same thing. Viral management, diabetes, hypertension, non-pharmacological measure when you answer proper education, exercise, diet control, stop smoking, it all works on. So the answer is actually very universal. But just remember a few. So all these will get marks on. Right? Non-pharmacological management is just exercise, diet control, proper education on compliance, all can gain marks. So how about the pharmacological management? Okay. Some of the slides is Dr. Wendy prepared one. So it's very comprehensive. So there are, when I say this one not important means you no need to go through second time. I think it's too complex for you because this is all adapted from the CPG guideline. So okay, this one no need. I remember. Okay. This one no need. This is too high five for you. This one no need. Okay, this one no need as well. This one also no need. Okay, this one no need. Yeah, this one important. So the above four slide, you can forget about it. So in a pharmacological treatment for acute on decompensated heart failure, there's only a few things. So when patient in decompensated heart failure, they comes with you with shortness of breath. They have difficulty breathing because the lungs are filled with fluid. So what you want to do? Because you want to give them oxygen, is it? They are hypoxic. They are not enough oxygen. You give them oxygen. So when they have a lot of fluid in the body, you want to remove the fluid. So you give diuretics like Lasix and spironolactone. Just remember Lasix, oxygen and Lasix. Those are mainstay for the acute problem. You want to remove the fluid from the lung. You want to pump in oxygen. Okay. Uh, and you want to add in vasodilators to help you to improve the oxygenation of the heart. So, and in acute decompensated heart failure, a lot of time their blood pressure will be very low. So you need something to increase their blood pressure. That's what we call inotropes. And if they are in pain, you give them morphine. So just remember these four: okay, oxygen, diuretics, vasodilators, and inotropes. So that is acute heart failure. Acute means that they comes into hospital, they are admitted, they are very sick. They require oxygen treatment. They require something. If you don't give them, they will die. So these two. All right. So what about chronic heart failure? Uh, Chronic heart failure means that they are walking around in the community, but they are having compensated heart failure symptoms. Those are things that this five pillar is something you need to remember. So last time we used to remember it by a mnemonic A, B, C, D. It's actually easier to remember. Lah. Like this is difficult, right? You have an easy mnemonic, then it's okay. A, B, C, D. A means stand for ARB or ACE inhibitor, which is number two. Lah. So what does ACE inhibitor and ARB do? They will help to remodel your heart muscles. So for them to pump more efficient. So A stands for ACE inhibitor or ARB or ARNI. And then B stands for beta blocker. So what beta blocker do is that it tells your heart to contract not so forcefully, uh, so that it reduce the consumption of the oxygen, so that they no need to use so much oxygen to contract. So that's what beta blocker do. And then the C stands for calcium channel blocker, but we don't use that anymore, so we remove the C. And then the D will be diuretics. Okay. And there are newer classes of medication, SGLT2 inhibitor. This is diabetic medication actually. How it works is that it helps to improve the sugar control, and it also helps to remove fluid from the body. And the study has shown that with the use of the SGLT2 inhibitor, it actually reduce the major adverse cardiac event with the usage of this medication. Okay. Okay. So if you want to remember how, you want to understand more uh, in management of heart failure, actually this flow chart is a very good idea uh, to, to give you an overview on what we do, how do we step up the management in heart failure, because there are so many medications, which one to use, isn't it? Which one to use first, which one to use next, or which one to use last. The correct answer is actually, if the money is not a problem, everything is available, and the patient's characteristic is enough, is good enough. The best way is actually to use them simultaneously. But a lot of time we are limited by a lot of factors. Patient may have renal impairment, patient blood pressure is borderline low, so you can't give all of the agent, because all of the agent can reduce your blood pressure, causing hypotension. So that will be a main limitation. And SGLT2 impossible want to use it on every single heart failure patient, but the problem would be the financial problem because it's expensive. It costs around 300, 400 per month. Okay, so let's look at how do we, what are the flow chart that is recommended um, in patient in management of the heart failure. Of course, they want you to treat the underlying causes of precipitating factor. If there's a sepsis, stop the sepsis. If there is a irregular heartbeat that is treatable, then we should treat it first. Okay, and uh, the main management of the heart failure, of course, that the aim is to ask the heart, pump, you wanted the heart to pump is more efficiently, more efficient, and reduce the cardiac oxygen consumption itself. So we want them to contract properly. How do we do that? We want them to control the heart rate. We don't want them to contract too fast because when your heart is pumped too fast, they cannot relax properly to have a proper refill and then to contract again. So what I mean is that when patient is tachycardic, they cannot have a proper ventricular refill. So the blood cannot return properly to the heart for the heart to pump up. So even though your heart is pumping hard with the elevated heart rate, the amount of blood that pump out is actually less when patient is tachycardic. So when patient is having high heart rate, so one of the management is adding this ibuprofen. So this will reduce the heart rate and to reduce the work burden for the heart. And uh, main backbone of the treatment of heart failure still they were adding on the ACE inhibitor or the ARB together with the beta blocker. And if it still doesn't work, then they will do something called LVAD, which I will show in a moment. So, okay, diuretics is good to know you're using it over and over again in heart failure patient is to remove the excess water. A lot of times, diuretics also has its own limitation, especially when the patient comes in shock, when the blood pressure is very, very low. There's no way that you can give high dose diuretics. You can only give a very low dose to help to remove the fluid. ACE inhibitor in the ARB, they are proven can improve the survival, but then the downside is that their renal profile has to be good for you to use. When the EGFR is low, you have problem with it because of the one of the potential side effects is hyperkalemia. The potassium will go high. They will have some population may not tolerate so well with cough and angioedema. Okay, this is another novel medication that is good for heart failure, something called entrestol. Is proven can improve the symptoms, reduce the heart failure, and increase survival. It's a combination of ARB and neprilysin inhibitor. Beta blocker is something that should be on unless there is a contraindication like heart block or bronchial asthma. Okay. Good to know, but no need to remember all these different drugs and drug names or the dosage. Okay. As for the medication, I know the medication it's very confusing because there are too many things available on the market, and just remember the main principle and the main drugs, which is like I want you to remember this one. Yeah, just remember these slides enough today. I want you to remember that A stands for ACE inhibitor or ARB, beta blocker. I want you to remember diuretics, and I want you to remember SGLT2 inhibitor. These four. Okay, those are the backbone of the heart failure management. Okay. So there's something called device therapy that can be considered, especially those are the criteria. what happened is not what we call cardiac resynchronization therapy. So when you have congestive heart failure, your heart chambers are dilated. So their conduction will have a little bit of problem because when they are spaced apart and their conduction left and right sometimes will have delay because the muscle now is bigger in size and they are further away, they are more swollen. So the electric signal does not reach the heart, different parts of the heart at the same time. So this make their contraction does not effective anymore. So imagine like your heart muscle, part of it contracting, part of it not. It does not squeeze out the blood at the same time. So it's not so effective anymore. So what this CRT do uh, is actually putting in three leads of sensor and also the uh, signaling wire and a pacemaker. So what this thing do is that it actually sends give replace the patient pacemaker. So this implantable CRT function is to give a new signal to the heart and ask them to contract at the same time. It's actually a pacemaker to resynchronize them so that the left side and the right side of the heart actually pumping at the same time. So there are few criteria for you to decide that the patient will benefit if let's say their EF is low, they are still contracting at sinus rhythm, and when they have left bundle branch block. So these ECG changes is actually telling you that part of the heart is not contracting at the same time. All right. This is something that we do have in our center. And ICD is another thing is for secondary or mainly is for secondary prophylaxis. Whenever we only do it whenever patient already has a previous episode of ventricular tachycardia, it's actually to give a life-saving shock when the patient has a recurrent ventricular tachycardia. So it's very important for someone uh, who have a scar VT before. So uh, our heart muscles, when they die off, when they have a STEMI or ischemic heart attack, they'll form scars. The heart muscle don't regrow like the normal skeletal muscle do. When they die, they form fibrotic scarring. This fibrotic scarring does not conduct the electricity so well, and sometimes it become something's wrong with them, and they actually can trigger a haywire signal itself, and that's what we call scar VT. So this scar produce signals that causing ventricular tachycardia, and when that happens, the heart is like becomes like a bag of worms that does not contract. They become like just moving non-control, and that can cause cardiac arrest. So implantable cardioverter defibrillator, it has a center and has a sensor lead and also has a shocking lead. So when it sends that VT, it can deliver a shock itself uh, uh, when the patient is outside of hospital setting. Of course, the last would be surgery now, but of course, you reserve with someone has the accessibility and fit to undergo CABG. Okay, I think that's it for the presentation. Any question?
No, doctor.
Yeah, so I think this is a very, very long slide. Some of it may be very complicated for you. The things that I want you to remember is very simple only. Uh, how does the heart failure present? Okay, just remember this few lah. Just jot down what do I want you to remember. How does the heart failure present? What are the risk factors of the heart failure? What are the causes or etiology of the heart failure? How do we work up heart failure? And how do we treat heart failure? Okay, just remember these five simple terms, these five things, these 5 points, and then just read recording to the slides. Then you get a little bit info about heart failure. Okay. So in exam, typical things is still how do we come out in exam with this? Usually we give you a picture, a picture of ECG, or sometimes we give you a picture of these, together with symptoms, and what do you think the patient has, how do you work out. So that's how you should know. That I give you this X-ray, you should be able to tell me what does this X-ray findings will show. Okay, this group of X-ray, this type of X-ray, you will come across again and again throughout the lectures. Right. Any other questions? Any questions at all?
No question.
Hmm.
No
You guys
question, doctor.
attendance, or you can end the call?
Can we take a picture together, doctor?
Uh,
Hips, where is
Intaji, Hannah, Larissa.
Tak nampak kita ke? Dah
Oh.
buka dah.
Okay. Larissa? Oh, cannot on. Okay. Ready? 1, 2, 3. Thank you, doctor.
okay.
Thank you, doctor.
Doctor.
Thank you, doctor.
Okay.